I'd like to welcome Dr. Michael Sutowski. He's a professor of ophthalmology, pediatric ophthalmology, and neuro-ophthalmology at the Dean McGee Eye Institute in Oklahoma City. Dr. Sutowski's clinical focus areas are pediatric ophthalmology, neuro-ophthalmology, and strabismus. He should give us a perspective of neophthalmic disorders in children compared to adults. Dr. Sutowski has authored over 60 peer-reviewed articles in pediatric ophthalmology and neuro-ophthalmology, and he's going to talk to us about approach to diplopia in children.
Thank you very much. I'd like to thank Rita and everybody else for the honor of being invited to your meeting. I'm very delighted to be here, and I hope this will be useful to you. So what I'm going to do at this point is go through kind of a simple algorithmic way to think about what the etiology of someone with diplopia is. And for the most part, this will pertain to both adults and children, but where it's peculiar between the two, I will let you know. The first step in dealing with someone with diplopia is to find out whether it's binocular or monocular. Of course, with monocular, there's no change with one eye covered, but it may be unilateral or bilateral. It's important to make sure you ask the patient to cover either eye so you don't miss monocular diplopia in the eye that's covered first. And binocular diplopia, of course, disappears with either eye covered. If it's monocular diplopia, you're going to find the answer almost all the time on the eye exam. And as you know, most of the time it's an anterior segment problem or a refractive error that's not corrected, like the list you see here. But there are some posterior segment problems that can cause monocular diplopia, including epiretinal membranes, edema, and macular ectopia choroidal folds. But again, you'll see all these on the exam. You can have monocular diplopia that's bilateral from central causes. It's extremely rare, and usually when you have cortical diplopia, it's polyopia, it's triplopia or quadruplopia. I've seen 2 cases in 15 years, but it's very symmetric between the 2 eyes, and often you're going to have a field loss, a homonymous defect with it, or some central dyschromatopsia or palinopsia, or some other sign of higher cortical dysfunction. So it's rare, but keep it in the back of your mind. And it's usually quadruplopia or triplopia, and it's exquisitely symmetric between the 2 eyes. And then we get to the rest of the people with binocular diplopia. And in these cases, most of the time, they will have strabismus. Now, the strabismus could be comitant or incomitant. If the strabismus is comitant, by definition, the eyes are going to move normally. The versions and ductions are full. But if it's incomitant, one or both eyes are not moving fully or over-moving in some direction, and then you deal with, is this restrictive or paretic disease? So let's look at the causes of comitant strabismus. One of the common things is a breakdown of aphoria. For whatever reason, normal aging or stressful situations or fatigue cause people to lose fusional vergence amplitudes, and their phorias break down into intermittent tropias that are associated with diplopia. One of the keys to recognizing this is that when their eyes are aligned, or whether you align them with prism, they have very good stereo acuity, 40 arc seconds, and they're bifoveating. Another common cause of comitant strabismus is vergence insufficiencies, and by definition, convergence insufficiency is an exodeviation greater at near, and divergence insufficiency, an esоdeviation greater at distance. In adults, almost all the time, these are idiopathic and may be associated with age-related loss of fusion amplitudes. But if it's a kid, you do have to think more about CNS disease. We're seeing a lot more convergence insufficiency in kids that are diagnosed with ADHD and they go on Ritalin or amphetamine-type drugs. There's a very high association there. And divergence insufficiency in kids is commonly associated with a Chiari malformation or some other problem in the posterior fossa, or perhaps a pontine glioma as well. So both of these in kids should raise a red flag, whereas in adults, not so much to worry about. Another cause of comitant strabismus is a decompensation of a prior strabismus or a monofixation syndrome. And often you will elicit a history of strabismus surgery or patching for amblyopia. One of the keys here is that when you align them prismatically so that they are able to see single, they have poor stereo acuity. They may actually not have any on the Titmus test, so they're not bifoveating. And the other key is that if you check their phorias versus their tropias, as opposed to patients with acute onset, they have very, very large phorias and much larger than their tropias. Now Now we'll get into incompetence strabismus, and this may be restrictive or paretic. And one of my pet peeves is when you see an eye that doesn't move fully in some direction, it's not doing a forced duction, because this is the point at which you need to know, is the problem at the muscle or orbital level, or is it somewhere else? If it's a myopathy, by far the commonest cause is thyroid disease. In fact, worldwide, it's the commonest cause of binocular diplopia in middle age. The medial and inferior rectus are most commonly involved, and usually you'll see other signs as well. Kids can get thyroid orbitopathy, and they can get lid retraction and proptosis, but strabismus is very, very rare. This is an adult with typical thyroid orbitopathy. You see elevation deficits and abduction deficits and a large ET. And classic example on CT or MR, the bellies of the muscles are very, very enlarged. The tendons are spared. And here you see very large inferior rectus on the right there. If you have access to orbital ecography, is this the pointer? You can measure the size of the muscle, and you see it's very, very large. And if you could do an A scan, you see the internal reflectivity is on the high side because there's a lot of water in here, as opposed to things like myositis or metastatic disease to the muscles that have low internal reflectivity. Dr. Lee mentioned Tolosa Hunt, and orbital myositis is the same thing as Tolosa Hunt. It's idiopathic granulomatous inflammation, but it's localized to one muscle. And this may be paretic or restrictive. It starts early on as a paretic disease, but if it's not treated, will become restrictive. It's very painful and exquisitely responsive to steroids. As opposed to thyroid orbitopathy, the tendons are thickened on CT or MR or ecography. Sometimes we as surgeons produce myopathies as well. Obviously, if you do a sclerobuckle or a glaucoma CTON or something, you can have restrictive eye disease from this. But retrobulbar and peribulbar injections are very common. This is a cadaver study that we published a couple of years ago, and you can see it's very easy to understand how a retro or peribulbar injection is going to hit the inferior rectus, and that's about 70% of the problem. What's a little less intuitive is how a peribulbar or retrobulbar block could actually hit the superior rectus. You see, with just you're in the lateral part of the lower orbit, just a slight change in the angle you hit it, you'll miss the inferior rectus, go medial to the optic nerve, and you're in the very posterior part of the superior rectus. So that's why 30% of the anesthetic myotoxicity actually does involve the superior rectus. Myasthenia gravis, of course, another cause of diplopia in children or adults. Problem with receptors to the acetylcholine, antibodies to the acetylcholine receptors. And the pattern of ophthalmoplegia is quite variable and often changes from examiner to examiner. Ptosis is usually present. In adults, 80 to 90% of the time, ptosis will be present along with the diplopia. However, in children, the presence of ptosis is much rarer. In fact, less than half of children who have diplopia due to myasthenia have coexisting ptosis at the same time. In adults, the distribution curve is bimodal with younger females and older males. In children, there is no sex predilection. It's definitive. A tensilon or intravenous edrophonium test is the gold standard, but you can do serum antibody receptor titers, only present half the time in purely ocular disease, but very common in generalized disease. You heard a little bit about cranial neuropathies. They often microvascular in the older age group with diabetes and hypertension. If you look at all the microvascular cranial neuropathies, about 48% are the third and 48% are the sixth. It's very rare to have the fourth nerve involved for reasons that are unclear. But as Andy said, they're usually isolated mononeuropathies, and most get better on their own. Obviously, brain tumors, you think about these, where there's direct compression of a nerve or papilledema with indirect compression, sixth nerve most common there. Idiopathic intracranial hypertension, again, can cause diplopia from a sixth nerve palsy, but actually 3, 4, 7, and 8 palsies have also been reported. And we're seeing a lot more of these craniovenous sinus obstructions, particularly in children. Trauma can cause cranial neuropathies, particularly number 4, because you have a very long intracranial course, and if you hit the back of the head where the nerves cross in the area of the intermedullary vellum, you can get bilateral paresis. 6th nerve, common with basilar skull disease. When 3rd nerve results from trauma, it's usually very severe trauma. Dr. Lee talked about aneurysms, so I will skip this for now. And obviously, intrinsic brainstem disease from whatever cause may cause diplopia. And we're looking for additional symptoms here, as has been mentioned already. Any kind of disease in the subarachnoid space can cause diplopia in adults or children. This may be infectious meningitis, sterile meningitis, carcinomatous meningitis, and you can pick off cranial nerves one by one, unilaterally or bilaterally. So the point is that if you have a situation like that, scan looks normal, you're obligated to tap and assess the CSF to look for some of these causes. Cavernous sinus disease can get the cranial nerves as well. You may see Horner syndrome from involvement of the sympathetics as well. And of course, infection, thrombosis, Tolosa-Hunt syndrome, aneurysms are all possible causes. So here's an example of a lady with a left 6th nerve palsy, but she happens to have decreased sensation in the 1st and 2nd divisions of the trigeminal nerve. This is a 70-year-old with acute diplopia. You might write off to vasculopathic disease, but think about examining for adjacent cranial nerve problems, and you see, lo and behold, she actually has a huge meningioma, and it's surprised that's the only symptoms that she has. So a brief focused neurologic exam can really help you in determining who needs to get worked up and who doesn't. Of course, when you get into the orbit, you're looking for things like proptosis or optic neuropathy, and things, thyroid eye disease, orbital cellulitis, orbital tumors can all cause diplopia here. Now, there are some situations where the muscles actually overact, and they're fairly rare, and some of the common ones where you hear a complaint of diplopia are superior oblique myokymia. They may complain of vertical oscillopsia, but often, at least in the early stages, it is intermittent vertical diplopia. Neuromyotonia, or overaction of a muscle-nerve combination, usually the lateral, medial next commonly affected. Thinking about patients who have a history of trauma or radiation therapy to the head or neck for something. And muscle scarring. In addition to the thyroid disease causing a restrictive problem in preventing movement in the opposite direction, anything that scars a muscle, especially if the scar is small and segmental, can cause the muscle to overact. So overaction of any particular muscle can occur in this situation. Then we have intranuclear disease, of course. Here's an example of somebody who's got a 1.5 syndrome. So the only thing is the left is the right eye is abducting, and there's a brainstem lesion on the MRI. And supranuclear disease can cause diplopia. Skew deviation may be common, but if it's incommon, it may mimic an inferior rectus paresis or a spear-brake palsy. I'm going to talk for a minute about central fusional disruption. This is a particular cause of binocular diplopia that is most commonly seen after restoration of vision in one eye that's been depressed for a long time. So, for instance, someone's had a cataract for years in poor acuity, they can lose their ability to fuse. But it may be seen after head trauma as well. And these patients have a very characteristic response in that there's no amount of prism that can align the images. If you put them on a synoptophore, they still can't hold them together, and they'll get them together, and then there'll be a vertical slip up and down of the images. It's very characteristic for this. And horifugiomas is patients who've had orthoptic therapy where they try to run anti-suppression exercises in childhood, and then they get older and develop some sort of decompensation of their strabismus, and they cannot fuse anymore. Visual field loss can cause diplopia as well, particularly bitemporal hemianopia or binasal hemianopia as well, because it's particularly if the defects are complete, you have a blind hemifield trying to match up with a seeing hemifield in the fellow eye, so you lose the corresponding retinal points. They don't have normal fusional vergence, and they can have variable vertical or horizontal strabismus with diplopia. Homonymous hemianopias in children can produce strabismus. They tend to develop an exotropia in order to maximize the remaining visual field that they have and improve their ambulation. And occasionally an astute patient will tell you that they can actually see double, but they prefer to do that so they can maximize their field. So here are my rules to dealing with diplopia. Number one, monocular diplopia is almost always due to an eye problem, the rare exception of central polyopia. Two, binocular diplopia is almost always accompanied by strabismus or a history of strabismus. If binocular diplopia is comitant, you're thinking of either a Vergence abnormality, and remember in kids the neurologic import is much more than in adults, or decompensation of prior strabismus. And the key here is getting a past history, and a big key is after you have aligned them prismatically so they're diplopia-free, check their stereo acuity and fusion potential. If they're not bifoveating, this is likely a decompensation of a childhood strabismus. Number four, incomitant binocular diplopia must be accompanied by a ductional or reversional abnormality. There's no other way for the deviation to be different in different positions of gaze. It might be subtle, but it's got to be there. If you see an obvious ductional deficit, you've got to do a forced duction, because this is the point at which you have to know if the problem is restrictive or paretic. And if it is restrictive, you're going to image the orbits. You're going to look for myopathies or orbital masses or some other problem like that. On the other hand, if it's paretic, you have to think about myasthenia. In my institution, the charge for a tensilon test is $70, where an MR in orbits is $2,000. So you're going to ask about ptosis and variability and check some other things. And finally, there's exceptions to everything, which include skew deviation and central fusional disruption. So, thank you.